Hey guys, it's Dr. Wong saying hi from Azusa and checking in with you this evening on Name That Pattern Live. And today we are kind of concluding our low back pain series. And so I've been thinking about this a lot. We're talking about generalized pain today and also the category from the low back pain guidelines called back pain with cognitive and affective tendencies, which is a clunky word, but it's a very important concept as we begin to figure out why is this low back pain issue such a big, chronic, and costly problem, okay? And does it have a lot to do with sources, tissues in the low back, and how do these people get that way, all right? So for those of you who are joining us this evening, we are finally coming to the end, kind of closing down the low back pain talks. We've gone over 4 weeks now, and we're tying this up. This is not an easy topic, and I've got 15 to 25, let's be real, probably 30 minutes to cover this topic, and I want it to be useful for you so you can take it and go with it. When you come to the clinic, you can understand some of these patients. So anyways, let me paint the picture for you. Again, we're talking about generalized pain today for those of you who are joining us. I want to paint the picture for you with a patient presentation. Okay, so we're going to look at the patient at 2 different time frames. So first, I'm here to see you for physical therapy. I hurt my back. I was busy lifting over the weekend, lifting furniture we were moving. I'm having very significant low back pain that is going down into my leg. Okay? And this pain is about an 8 out of 10. From the questions that you're asking me as the physical therapist, I'll tell you that my 8 out of 10 back and leg pain, this happened about 2 weeks ago. This back pain, I feel like has not gotten better. And my primary sport is I love to cycle. I cannot even sit in the car. I cannot sit in class. And I'm really worried that I cannot even finish this semester because I can't even sit still in class. So I haven't even gone to class for the last week and a half. Okay, so all the work's piling up. My instructor is emailing me about where I'm at and telling me that if I don't attend my classes that I'm going to have to take an F for the quarter. And I don't even know how to deal with this. For that matter, I can't do any of the sport. I can't even get my pants on, right? When I try to bend forward, I can't. I've got so much pain in my low back. And I know that this has happened before. I've had this before, and I don't know if I can handle this right now, okay? So what I'm presenting as to you, for those of you who have just heard the history, injured my back 2 weeks ago, I have back pain, and I also have leg pain. Let me give you a picture of what that looks like. Okay? So I have back pain and leg pain. For those of you who are out there, what category do you suspect? What are your hypothesis categories that I might have? Because I'm asking you, based on the patterns from the guidelines, what kind of pattern do I fit? Okay, so I'm just putting it out there for you guys. What kind of patterns do I fit in the categories that we've talked about? What are your hypotheses? So let's get your typing fingers out. What do you guys think? The patient has low back pain. I have pain going down into my calf region. And what makes me worse is any types of sitting, trying to put on my pants, brings it on. What are some of the categories or hypotheses that you think I might fit? Okay, because we're going to connect some of this to some of the things that we've talked about in the previous days. What are some of the categories that this patient might fit? Joe's got possible centralization. Okay, good. So that would be a category, absolutely. Instability. Hampton's got instability in there, right? Because my injury occurred in some of these movements that could be related to any of these particular categories. Anybody else? What category in the guidelines, instability category would be considered back pain with movement coordination impairments. I injured myself with an excessive movement of flexion, right? Charlie's got low back pain with referred or radiating pain. He hits two birds with one stone. Nice, Charlie. So the guy has leg pain. So from the guidelines perspective, Malaku says back pain with related leg pain. Perfect. Now, because the patient has leg pain, automatically, based on the guidelines, in your mind, as you're recognizing the pattern, you are saying, hey, you know what? I think he might have radiating pain, or I think he might have related leg pain. So for those of you out there who have these hypotheses, and there's no question, is instability potentially a part of it? Absolutely potentially a part of it, but you have these two categories that they fit more clearly. Will this person, after you manage the leg pain, eventually be an instability category? Absolutely, he can. The guideline says these people transition from category to category, okay? But when you have this type of leg pain, what can you do to actually decipher out, is this a person who might centralize? Like someone mentioned earlier, that was, let's see, Joe mentioned possible centralization. How am I going to tease out, is this related leg pain, or is this radiating leg pain? What do you guys think? In your exam, in your physical exam or your key findings, how would you decipher the two? So Andrew says, repeated movements using directional preference. If I came in with some type of shift, a loss of lordosis, some type of repeated movement, and the presence of centralization, right on Andrew, would then imply that this was a related leg pain problem, a referred leg pain problem from disc. Okay, absolutely possible. What if I was the other guy? What if I was the radiating pain guy? Repeated movements only made me worse. Okay, repeated movements of extension made the burning in my pain in my leg worse. What kind of test would you then do to help prove your condition of what category you feel like you're in, right? Because we've talked about this related leg pain category, and we've also talked about this radiating leg pain category. So what would you do in your testing to prove that I don't think this is centralizable leg pain? I don't think this is related leg pain. So Charlie says, if radiating, I should find positive neurodynamic findings, right? So potentially a positive straight leg raise, potentially positive neurologic findings. Exactly, right? So we've got one group of leg pain that you are using centralizing procedures. Malaku says SLR, exactly, doing some type of test to prove neurodynamic involvement. Okay, perfect. And Joe's got slump testing. Now, remember, Joe, that's a good thought, except that the person's only 2 weeks out. He's already told you his excessive movements of flexion are what bring on his pain. So the risk then is our testing putting the low back in increased risk? So it's the right thing to think about, but irritability will always trump what kind of test we choose. We always have to be careful of the structures that we're going to compromise to get our testing done, okay? So now, this is not the key part of today's discussion. I want you to think about some other things that you noticed. What are some other things that you noticed that would put me in the category back pain with cognitive and affective tendencies? What are some things that I said that begin to raise your radar to say, hey, something else might be going on? So just take a moment to think about what are the kinds of things that I said. I'll also tell you, I always typically train 4 days a week on my bike. I don't even want to look at my bike. Okay, I can't even get myself out of bed because I'm so worried about my low back. Okay, I'm so worried that this problem is not going to go away. And I remember when I hurt myself in my low back, even knowing the things that I know about how to manage back pain, I was worried, okay? I haven't gone to a class in a week and a half. Do you see all of a sudden a spike in disability? Okay. What else? Okay. Vincent says fear avoidance. I can't even put on my pants. I can't get on my bike. I don't even want to look at my bike. The things that used to bring me joy and pleasure, I can't even fathom looking at it. Okay, so I've got some fear and I've got some depression. So, Jesse says, worried about failing grades. The point about cognitive and affective tendencies, Jesse, by the way, good thought. The thing about these cognitive and affective tendencies, right? The patients coming in, yep, we can even talk about the start back screening tool. I gave a presentation at California chapter using the start back screening tool. You are beginning to see in this patient, okay, the guideline says 2 categories, acute and subacute low back pain of any variety, mobility deficits, movement coordination impairments, radiating pain, related leg pain, any of those categories with an overlay of cognitive and affective tendencies. I'm down. I'm showing signs of depression. I have some signs of fear. I have some signs of potentially catastrophization, which you can use a pain catastrophizing scale to kind of gather this data. So what begins as a typical low back pain patient who's beginning to show you signs of cognitive and affective tendencies, right? This is coming out in the subjective. You're just looking at them. Look at their affect. Listen to the things that they say. What is their disability, and does their disability match what your expectation of this type of problem, right? Is that consistent? If he's in very acute low back pain, some amount of disability is absolutely expected. But I would tell you that the good therapists, as they recognize this, right? The guideline says subacute or acute low back pain of any category with one or more of the following, and that is a couple of questions that you can use to screen out depression, okay? So these 2 questions that I want you to have into your mind, what do you think these 2 questions are asking? One is, do you feel depressed or hopeless? Within the last month, do you kind of feel depressed or hopeless? And you can kind of hear that, tease that out already in the subjective. The second question, which ties into the biking, is, are you bothered, within the last month, are you bothered by little interest or pleasure in doing things? What are the kind of things that you love to do? Have you been able to do that? I would encourage people, right? I purposely encourage people to start doing the things that they enjoy to do, as long as I teach them how to do it without compromising their back. Because this is tied into the guideline-based principles, and we'll go over those. 2 don'ts, 6 do's on what the guideline says to do with these types of patients. Okay? So, keep that in mind. Any category of low back pain, acute or subacute. Okay? Any acute or subacute category of low back pain, including mobility deficits, lumbar sprains and strains, your back pain with movement coordination impairments, your leg pain, right, radiating. The point of today's talk is not exactly which category it is. The point of this talk is any one particular low back pain category, which is what I'm asking you to do as a young clinician or as a seasoned clinician, is to think about what are the main categories, which ones do they fit, and do they have an overlay of cognitive and affective tendencies. Okay? Because immediately when I hear those things, I automatically challenge unhealthy thoughts and teach them ways to overcome these unhealthy thoughts. Because if that is not managed properly, this says 3 months later, of course it's backwards. This is what the patient looks like 3 months later. Okay? So back pain, whether it was radiating leg pain or whether it was back pain with related leg pain, didn't matter the category, because now, 3 months later, what usually happens? Let me ask you, for typical low back pain, what is the typical course of low back pain, let's say at 3 months? If you're doing generally the right thing, right? What happens to low back pain? Do people get better or do people get worse over time? What do you guys think? And this ties in. Kenny says, yeah, low back pain, just like any other tissue injury, right? In the early phases of the tissue injury, right? This is day 0. At the early phases, pain is high, inflammation is high, disability is high. But as the tissues heal, the pain, the anxiety, the disability, all of it goes down. This is normal tissue healing. The low back is no different. It's just that some structures in the low back are slower to heal, no question about it. And 2, the low back is so central to our function that when it goes bad, so to speak, it's so devastating, right? And that ties into these cognitive and affective tendencies. So what would you tell me, okay? You noticed at 2 weeks, these were the kind of things that I was telling you. Just type in for me a quick blurb on the things that you would have said to me in that moment that would have been valuable in popping me off the slippery slope towards generalized pain. So just take a moment. Think about the things that we had just talked about. What kind of things would you have said that could begin to change my course to prevent me 3 months later from becoming like that? And we'll talk about why I became like that. But take a moment. What kind of things would you have said to me that could have changed the course of my low back pain? Barring, not even considering whether you were doing the right PT or not. I'm just saying in that moment when you were in the subjective exam, what are some of the things you could have said to me? How could you have shaped the way that I'm thinking about my low back and my disability and my plan on how to get out of this problem? So let's see. Vincent, Jesse, Malaku, Joe, what do you guys think? Kenny, what kind of things could you have told me? And we'll see if they match what the guidelines are telling us to do. What kind of things could you have told me that would help me move away from the slippery slope towards generalized pain? What do you guys think? Let's see, Weisia says, your back is very strong and a stable structure. It will not be gravely injured by doing everyday tasks. Lots of great things loaded in that question, in that comment. Kudos to you. Kudos to you, Weisia. That is actually a very guideline-based comment. Anything else? Specifically to how about my concern about sitting in class or riding my bike? Is there anything that you could have told me? Jesse says, back pain is an extremely common problem and many people recover fully. Right on, Jesse. Awesome. Exactly. We already have covered three of the 6 do's. Joseph says, pain neuroscience education. You guys are awesome. Okay, pain neuroscience education. I mean, that's a topic for another quarter, right? But could you help the patient understand that pain doesn't mean, the fact that he's still in pain doesn't mean that his healing process is not working. And that pain is totally normal. It's part of a warning system that helps us to be careful temporarily because the structures are irritated. So absolutely, I think, Joseph, you're right on. The guidelines actually said, and in the guidelines it talks about Mosley doing a study where pain education reduced disability in the patients just by the way, pain science education. Hurt versus harm. Vincent's got, sometimes hurt is okay and it's completely normal. And pain, remember, is an emotional response, right? It is not a guarantee that tissue is being damaged. And in this patient's case, at 2 weeks, there's no question he had hurt some tissues, right? Okay, you guys are right on. So, a few things that the guideline says in that moment not to do. Two things not to do. One is do not pull out the spine. I don't have my spine right here right now. Do not pull out the spine with a big red herniation and show them that is why your back's hurting, right? All of us can agree that extra imaging potentially can drive the patient into more fear, more anxiety, okay? So no need necessarily, barring that there's no significant or progressive neurologic deficit, our goal is not to increase fear, right? And do we really know, as physical therapists, which structure it was to begin with, right? We can hypothesize. I don't think it's useful to necessarily tell them exactly what it is. Then they'll go and search it out, right? Dr. Google, what happened to my disc? And then all of a sudden, all your work is undone. Okay, so that's the first thing. Secondarily, the patient should be told, you know what? Actually, it's okay to go and do some of the things that you enjoy doing. Don't stay in bed. Avoid bed rest. Okay, the guideline says these two main things for this group. Start getting active. And I'll tell you one other thing as we understand the pain sciences more, the patient's ability to focus on something else. Okay, focus on something else besides his disability in low back. Get him back to active movement, to his active life, to doing things with people, because his focus is changing and it's not just winding itself up in his brain, okay? Perfect, so you guys are right on. Now, let me move on to how does the patient end up looking like this, okay? First, let me just say, the patient started with a very typical back pain with related leg pain, okay? Or radiating leg pain. And the therapist, if he managed him right, let's say I centralized the patient's back pain, I taught him to not fear pain because this would continue to improve. I always tell patients, hey, you know what? Your back is already healing. Your back is a very strong structure, and just like any other structure in your back in your body, your back can heal. So it's okay for you to feel this way. It's very normal. As you had mentioned earlier, lots of people have low back pain, and almost a large number of them will continue to improve. This is just a very normal thing that they're experiencing. So the patient doesn't feel like they're all alone. They're in this dark place by themselves. And the therapist, the skill of the therapist is to recognize when you need to add a little bit of that extra, right? Extra positive vibes, extra positive education that counteracts the things that are going to drag the patient down towards generalized pain. Okay, so you guys are right on. The generalized pain component. Why does the patient now have pain in so many locations? Any thoughts on that? Is he injured? Has he injured his neck? Okay? Has he injured his thorax? The patient's not doing anything. 3 months later, he has failed out of his class. He has not gotten on his bike. As a cyclist, we all feel fat, right? The moment we stop riding, we feel like we balloon up. So he's stressed. He's becoming increasingly disabled. But the time frame since the injury has occurred has just increased, right? With time, disability and pain usually go down. With this guy, disability and pain continues, even well past normal tissue healing. So, one, the therapist may not have done the right care, okay? They're guaranteed that's possibly one of the causes. But secondarily, as the patient is winding up in their mind and continually focusing on this pain and worrying and not being able to do the things that they enjoy and having all of these stress factors, can you see how the brain now is becoming increasingly sensitive to danger, to stress, to fear? The catastrophization is going out of control. So now, all of a sudden, things that used to be a little bit of discomfort here and there, a little bit of discomfort in my back, all of a sudden the patient says, hey, I feel pain now. Not because there's true tissue injury, but because the sensor is now wound up, hypersensitive, right? How can you explain that the guy who I probably, if we did it right, we could have centralized his leg pain. His pain would be gone. And after that, we teach him how to bend, we teach him how to squat, and we would do motor re-education to prevent recurrence. And once we've done that, the patient's gone. Okay? Probably won't have the injury again because we've already trained him how to move. But instead, if we put him in the wrong category and we do not address the things in his mind that are creating a wind-up in his sensitivity, right? Then all of a sudden the patient begins to feel pains in places with movements that are inconsistent with the patterns that you would have said, oh, that's typical of some type of radiating pain or related leg pain. Flexion movements reproduce the pain. Great. This patient now says, when I stand for too long, I get pain down both legs. When I sit for too long, I get pain in my right leg, and I get pain in my neck and in between my scapulas. Can you see how tricky that becomes if we keep chasing the tissue source? You cannot, it is unlikely that you can fix each of these problems by chasing tissue sources. So, with that in mind, can we agree that generalized pain, the guidelines calls it chronic generalized pain. And how did he get there? Because he was acute or subacute low back pain of any category that had an overlay of depression, catastrophizing, and fear. So the guideline says these people, as they head into this chronic 3-month or greater pain, now have signs and symptoms that are inconsistent with any particular pattern. Sometimes extension hurts my left leg. Sometimes standing makes my neck kill me. Sometimes when I sit for too long, I have right leg pain, but not left leg pain. You cannot explain it mechanically. But the wind-up, the sensitivity of the brain, can help us to understand. So now, let me put it back out onto the table for you guys. The patient looks like this now. He's failed his class. He hasn't been on his bike. He doesn't want to get out of bed. What are some of the things that you have already learned, that you've already done, that you would do to manage this patient? Okay, so let me just put it out there. Joseph, Vincent, Jesse, Malaku, what do you guys think? Weisia, what kind of things would you do for this patient that can help restore this patient to pain-free, hopefully pain-free life, but if not pain-free life, to function at least? So what do you guys think? Let me put this up here, see what you guys have to say. What are some of the things for this patient who is now, you don't believe to be truly just musculoskeletal pain, right? We think that this patient now has generalized pain, signs of fear, fear avoidance, signs of catastrophization, right? Depression. Okay, Jeff says patient education, absolutely, and I think that ties in nicely with pain science education. Lumbar roll, begin to show them movements that don't cause pain to reverse their process. That's a very interesting thought. Jesse, nice job. What could we call that? The patient says, I am very scared of bending. Have him ride a bike in the clinic. Nice, because you are standing by his side, you are maintaining him in a neutral spine, and you're getting his legs to move and bumping up his aerobic capacity. It's good thoughts. Actually, these are very good thoughts. Other thoughts on what you could do to help him, because his world has become very small, right? He is trapped by his misunderstanding of his pain, and his misunderstanding that this pain clearly means that there's structural damage. Weisia says, needs reassurance that his back pain will improve. He won't be like this forever. Perfect. Andrew says, graded exposure, graded activity. Okay, think about graded exposure as I want you to think about the time where you think about things related to bending that you're worried about, okay? And maybe instead of, and know that right now while you're laying supine, there's no pain in your back, okay? I want you to just think about it. Expose them to these potentially painful thoughts, painful movements, and then try to associate those things with happy things. So instead of saying, imagine when you're bending and hurting your back, you can think about, imagine if you're bending and you're picking up your nephew, okay? Can you tell that in supine you don't have pain? That's okay. So you're exposing them to these thoughts of lumbar flexion. And then when we talked about graded activity is, hey, let's put you on an exercise bike, okay? You like riding bikes, let's get on the bike. Can you see that if we keep your back close to neutral and you're moving your legs, you're okay? The doctor, the physical therapist is saying, don't be afraid. You can move. So you're slowly widening his world. You're walking side by side with the patient. In the meantime, it's absolutely okay for you to be addressing impairments. Tight hip flexors, tight hamstrings, these things are okay to manage. They're probably deconditioned. But you are actually helping him improve his world and expand his world. Let's see. Kyle Wolf says, Manny Young is the, I cannot exactly see the shape, but that looks like the big dog, the cool guy. So I'm going to call that Manny Young is the big dog. Kyle Wolf is saying hi to Manny Young. Think about, okay, the guidelines saying that we want you to help patients understand what pain is and why it's normal. And we want you to stay active, okay? Get back to your regular life. Start focusing on other things. That doesn't mean that you shouldn't be doing your movement science type of teaching them how to bend, teaching them how to move without compromising their back. Because initially, the tissues need to heal, right? The tissues, now at 3 months, the tissues are probably mostly healed. We need to start winding down his sensitivities, right? So overall, people, back pain's getting better. Use active coping strategies, as the guidelines would also say, and then don't have the patient focus on pain all the time as the measure of improvement. Have them think about their life being able to do more. Encourage them. Find out, how are you doing this week? How much were you able to do? Encourage them into activity, especially now that you've trained them. Okay? So, in summary, these are all great thoughts. In summary, I want you to think about the low back pain category of back pain with movement coordination, back pain with cognitive and affective tendencies as any potential low back pain category that has these little yellow flags, right? Depression, anxiety, fear, catastrophization. And when you hear these things, do not miss the moment to address them with positive things. Your back is very strong. It is already healing, right? Back pain gets better. All of these thoughts are things that you already push to counteract their own fearful thoughts and get them moving, right? But teach them how to move in ways that the back is actually in a position that can heal well. From there, you move on, and hopefully by doing that and you're doing appropriate physical therapy, you're doing centralization procedures. If it was a radiating pain problem, you would reduce entrapment, teach them to move in ways that doesn't compromise the tissue, right? And then do your nerve glides. The patient's continue to improve. You've reduced his fear, and the patient veers away from going down towards generalized pain. When the patient goes into a generalized pain category, this is a different category. You guys are all already on the right track with the way that you're thinking about managing them. You have to understand that this guy here, right? This guy here, though he may have some musculoskeletal dysfunction, his pain experiences are probably not directly related to tissue injury. They're probably related to something you need to manage here with your pain education, your reassurance. Maybe the patient needs multimodal care, okay? But you guys are all on the right track. This pretty much concludes, right, the main categories that the guidelines talks about for low back pain. Back pain with mobility deficits, back pain with movement coordination impairments, that kind of fits the sprain strain, right? Back pain with related leg pain, and back pain with radiating leg pain, right? So there's those 4 categories, plus any of those 4, plus cognitive and affective tendencies, can eventually end up as chronic generalized pain. This is what the guidelines talks about. When you have back pain patients coming in, I would advise you first to try to place the patient in a category, the category that matches the best, right? Should I mobilize him? Is he just stiff? Is he a mobility deficit? Then let me mobilize him and see if his disability gets better. Is he a movement coordination impairment? When he moves out of neutral, does he strain and sprain tissues? Because those patients, I need to neutralize their spine and teach them to move with neutral spine, right? Use their hip hinge, right? Teach them strategies that minimize stress on the healing tissue, right? So your lumbar stave stuff. That category fits that group. What about the radiating pain and the related leg pain? The related leg pain category, centralization procedures. Centralize the pain. If it's a radiating pain problem, yes, this is the most important thing. Vincent, you're right on. The most important thing to do when the patient is standing in front of you is to put him in the best classification category so that you can start testing the appropriate treatments on this patient and watching the results, okay? Testing, scientifically putting them in a category and matching the treatments. So from there, by doing this type of classification and recognizing how cognitive and affective tendencies can lead to chronic generalized pain, by understanding that big picture, and also keeping in mind, right, what do I do when I've centralized their pain? When they no longer have burning pain down their leg, you have to change the way that they move, their movement strategies that have caused this problem to begin with. Are they excessive flexion type people? Are they excessive extension type people? Or do they excessively rotate? All right? You guys, this was an awesome session. I'm glad you guys were there, engaged, talking about the things that, as we're organizing your thought, this pretty much concludes low back pain. We'll have probably one more session next week before we kind of take a break. Everybody wants to take a break and spend time with family. But thank you for joining me this evening. Looking forward to chatting with you guys more. Keep shooting good thoughts. Visit us on on Facebook. Let us know topics that you're interested in talking about, what other patterns we're interested in talking about, and then we'll continue to do this. Jeff, thoughts on MRI and its role in increasing this issue of psychometrically derived pain? So Jeff, yes, we can take just a few questions. Jeff, the guidelines actually suggest that for this type of people, that looking at imaging, in fact, will probably is probably detrimental to this group. So random calls for imaging have probably a much higher likelihood of increasing disability and driving the patient down this road that says, my MRI says I have 5 bulging discs and degenerative spine disease. Right? Vincent says catastrophizing and sick listing after MRIs. Exactly. So all of you guys are talking about the same thing, in that if there is progressive neurologic deficit, which is why you do a neurologic exam for this patient, right? He had pain going below the knee. So even though he was acute low back pain less than 16 days, you took note of his neurologic exam so that over the next few weeks you could remeasure that and assess, is your neurologic signs changing, getting worse? If that's the case, you refer out. The physician then decides, you know what, we need to go in and take a look because there might be something important for us to do, right? The risk is higher because he's progressing, he's getting worse. But in their standard cookie cutter low back pain, the imaging doesn't tell us much. 50% of us on this chat, 50% of us have findings that are considered abnormal, and we may have no pain whatsoever. But can you imagine, to the person who is experiencing some pain, just the words, you know what, you have degenerative disc disease. This is why your back is getting worse. This is why you're injured. Can you imagine what that imaging, whether we know it's related or not, what that imaging can do, push someone over the edge, right? Strong says relate MRI is an image in that moment of time and does not mean it's going to be the cause. Yeah, exactly, right? The MRIs are often static images, and we can't even associate very well those images and their relationships to the symptoms. I remember when we were treating a lot of patients in China, every patient walked in with this big envelope, okay? And this envelope was the answer to why they were having all this pain. So every patient was getting an X-ray or an MRI, and they would have this report written that they would take home. Actually, all these patients, they take this home, and they carry this burden around that says you have degenerative disc disease, you have space narrowing, spinal stenosis, and then they go and find out all the other extra stuff, all the juicy details about why their back is in so much problems. And so the moment that occurs, what we had the residents and fellows do was you immediately take that image and you help them understand that, you know what, actually these findings are very common. And in 50% of patients who have no pain, they also have these findings. So actually, don't be afraid. You're in the right place. You're with the spine specialist. We're going to help you get better, right? Vincent says, I give the patient an analogy, comparing a movie poster to the actual movie. The poster gives me an image in time, but doesn't tell me much about the movie, the whole picture, right? That's what you're saying, Vincent? It doesn't give you a picture of the patient's whole life. So any of these little analogies, anybody else have any analogies out there? Things that they like to use to counteract some of these negative thoughts, right? So I think related to this MRI idea, granted this is not our call to make a call for the MRI, but I'm very careful, right? One, I'm very careful about talking about source structures to the patient because even I'm not clear. Even I cannot truly diagnose that source structure. Okay? Two, you don't know what talking about source structures will do to someone's mind. Okay? I do tell them there's probably something that got slightly injured in your back. It's just like any other tissue, it heals. And you know what? There's lots of tissues in the back that are very strong, right? These tissues heal. So immediately, with almost every negative thought, I have a counter positive thought. For an MRI, I have a counter positive spin because you are trying to shift these people off of the wrong track. Okay, you guys, this is great questions. I look forward to, actually you guys continue to post questions on Facebook and also thoughts about other categories. Yes, I try not to use the word injured and instead I say, yes, exactly. Your tissues are very irritated, right? And these tissues will also continue to heal. So good call, Vincent. Continue to, Joseph says, I use the alarm system analogy. Charlie is like, pain is like the wind. You can see it, but you can't see it, but you can feel it. You can't see how it impacts the environment, but that's it. That's why images don't tell the whole story. Guys, all of those things that you are sharing back and forth to each other, we're helping each other manage these patients better. So send us some thoughts. Send us some thoughts on what kind of things, what other categories you want to talk about. We will pick this up again next week. Thanks, guys, for joining in and all your excellent thoughts. Keep up the good work, and look forward to seeing you guys next week. Have a great evening.